Welcome back to the Build Beyond podcast. For this episode, we welcome back Dr. Nichole Ellis. Nikki was on the podcast on our 9th episode. This is episode 73. So she was one of our original 10 guests. So it's really exciting to have her back. Nikki is the owner of the Pediatric place. She is a pediatrician. She's actually the pediatrician for my kids. She is the chief of staff of Hillsdale Hospital. She is a mom, a wife, an avid CrossFitter, and a friend. So I'm excited to have her back. This was a really fun conversation. And we talk about some pretty intense topics. And so we start off talking about the inverted food pyramid. Recently, the federal government flipped the food pyramid and is putting a different spin on nutrition. So the recommendations, some of them changed, some of them didn't. It's kind of confusing. You might be interested to hear Nikki's perspective on nutrition and the inverted food pyramid. This conversation ultimately leads us into talking about GLP-1 medication for kids. So the more common name out there, or one of the more common brand names, is Ozempic. So is there a place in pediatrics for medications like Ozempic? Nikki has an opinion on that as well. So I think you might be very interested in her take on that subject. We move then into the vaccine topic. The federal government also recently updated the vaccine recommendations. So the CDC has altered the recommendations, and then the American Academy of Pediatrics does not at this time necessarily agree with those recommendations. So Nikki explains the update in the recommendations and then gives some insight, at least in her opinion, why the two organizations, the CDC and the American Academy of Pediatrics, may not agree. So if you've got kids and you've got questions about vaccines and the changes in vaccines, this is a great episode for you because Nikki will explain it. We finish up with a hypothetical question. I asked Nikki if she could change one thing in America, and that one thing would last for the next 100 years. What would it be? What would be the one thing that she thinks would give us the most bang for our buck and have the biggest effect on the health of the United States? I love her answer. I think you're going to love her answer. So you've got to listen to the end of the podcast for that one. This is an exciting episode. I'm really excited to put this out there, and I hope you guys will like it. I am going to link all of Nikki's contact info. I'll list it all in the description. And so if you want to get a hold of her, or you want to get a hold of me, it should be easy enough to do. All right. I hope you enjoy this episode, and thanks for listening. All right.
Hello.
Welcome back.
Thanks.
It has been, it's been a while because I think you were this is probably 74th episode, maybe 75th.
That's incredible.
Yeah, I've been pumping out an episode a week for a while now. Wow. And I don't remember, you were maybe episode in the teens or something like that.
That's great.
So it's cool to have you back. And a lot's changed since the last time we talked.
Yes.
So there's a lot of things that have changed recently.
Yeah.
And I think they affect everyone as individuals, but they affect all different healthcare providers. But as a pediatrician,
especially,
some of this stuff has got, the questions and the concern that you must be fielding right now for some of this stuff has got to be overwhelming, maybe. Because it's like the current administration has taken everything and flipped it upside down.
Yes.
And some people agree with it, some people don't, but we can all recognize that things are different now.
Yeah.
One of the big things that happened fairly recently was they inverted the food pyramid.
Yes.
And the guidelines are, I think, a little confusing. Mm-hmm. But my thought was that, that what we were doing clearly wasn't working. Mm-hmm. And then they decided, well, let's just do the opposite.
Yes.
And see what happens. So do you feel like this change in dietary recommendations is going to have a positive effect, a negative effect? What are your thoughts on it?
I think that, when this all came about, I was kind of frustrated because I'm like, oh my goodness, there's so many aspects of being a pediatrician or being a physician that are so difficult. And why are we making this harder? But then the more I really thought about it, the more I really realized that this was an opportunity. And what do we really want? We want to make sure that we're always having a conversation, an open conversation, open dialogue with parents and with children so that they can understand their health and be a better advocate for their health. And so I thought, okay, well, this is going to bring in a lot more questions. I don't have to look at that as a bad thing. And I think I understand the reasoning behind flipping the food pyramid. We're trying to make something that is more nuanced and pretty complex and very difficult for families, very simple. And that is hard to do. It's just hard to do. And I think what I would imagine is a big part of what they were looking at was to move away from simple sugars and processed foods. And if we inverted the pyramid, you de-emphasized foods that are typically more processed. What I think would be probably a better way to look at it is really try to educate families on macronutrients as opposed to like creating a pyramid, to understand that we really don't have fruits and vegetables and bread as three separate compartments. They are all part of the macronutrient carb. And a carb isn't a bad thing. It's like not an evil word. But a component of a macronutrient, actually a very important macronutrient for children as they're growing and developing brains require that for fuel. That is what our brain uses for fuel. Just like fat isn't bad or evil, it's the building block for our brain. And so we need these things we need all of these things and kind of looking at not necessarily what box they fit in, but the quality of the things that we're putting in the pyramid. And that matters way more than where something is on the top or the bottom.
I feel like when they flipped the food pyramid, I was kind of confused for a second because they were like, oh, we're getting rid of the old and bringing in new. But in my mind, they had gotten rid of the food pyramid a long time ago.
Yes.
Michelle Obama introduced My Plate.
Yes.
And I had an opportunity a long time ago to meet one of the registered dietitians who sat on those committees. And I remember asking him, is this like, what was the process like? And he said, well, we were really trying to be realistic.
Yeah.
And I remember him saying that a lot of the criticism would come from the fact that they would say, well, Michelle Obama doesn't eat this way. And he said, we had to be realistic with people who have different financial situations, different levels of education, different cultural norms. And so they were trying to make something that was really simple. So shaped like a plate, you could roughly portion things out. I think we could nitpick on whether the portion size were right or anything like that. But I feel like that was at least a logical attempt. The interesting thing is I don't know that it actually had any positive benefits.
Yes.
Which I don't think is negative about their plan. I just don't think anybody follows guidelines. So that's the interesting thing too. It's does flipping the food pyramid even matter? Are people actually going to go change the way they live because there's an upside down triangle now instead of I wonder what the actual effect of this is going to be, or if it's just for shock value. Yeah,
and one of the things that I liked about the My Plate, and I agree with all of the criticisms that it shared, that there's nuance, there's cultural and family and economic reasons why this would be easier for some families versus others. But one of the things that I thought was nice about the plate is that it allowed you a guide in your head of what your plate should look like. Whereas a pyramid, you're not eating off of a pyramid, you're eating off a plate or, out of a bag or whatever you're eating out of, but that could have, the idea was that it could have a more day-to-day reference on what your plate should look like. And do you have something from that macronutrient that's on your plate?
Yeah.
But again, it's not necessarily what compartment something is in, but the quality of what you're putting in there. And I think that that's the drawback of this idea of a pyramid. But I think the real push there is where the focus is. And I do see that. I do see families are like, oh, we should be focused more on protein than we should be focused on carbs. And I think that because we are in such a polarized environment right now, I think it's really important to realize that it doesn't have to be carbs or protein, or fats or proteins, or sugar-free or fat-free, but that we're looking for balance. And I think that is sometimes when we're talking about pyramids or flipping things or doing something drastically different, you miss out on that key concept of balance. And what does your balance look like? And your balance can be a balanced plate at each meal, but what would be probably more realistic for most families is a balanced plate or plates over the course of a day or over the course of a week, especially when you're trying to feed a toddler. I mean, like toddlers as they're growing have developing palates. And so they may not like something the first 200 times you give them. And the 201st, they're like, oh, maybe I do like green eggs and ham. You just see that and you're just like, keep trying, keep exposing. Your toddler isn't growing at the same rate that your baby was. And so there'll be days where they eat more than you do. And some days they don't eat enough to keep a bird alive, and you try to find that balance for your family over a few days.
Yeah. I was trying to explain to a college student one time, it was recently they were talking to me about kids.
Yes.
And I was like, they're asking me like, the best and the worst parts about having kids. And I was like, the best thing is I have unlimited access to chicken nuggets 24/7.
Yes.
And the worst thing is that I have unlimited access to chicken nuggets 24/7
Yes.
because we have 8 different kinds depending on what they want.
Yep.
They need to be shaped like dinosaurs. Sometimes they need to be in stick form.
Yep.
It's just all different kinds. And I have my pick in the deep freezer. I can go anytime I want and make any kind of chicken nugget nuggets. You could think of.
Yeah.
But yeah, right now my kids are super into raspberries, and we were laughing the other day that at some point we're going to serve up some fresh raspberries and they're going to be like, ew, why do we want these?
Yes.
This is disgusting. It's like you've been living off nothing but raspberries for a week.
Yes.
But it's hard. With little kids, it's so hard to find balance.
Yes. Yeah. And that you're just really trying to make sure that you're exposing to different things. I mean, my son was extremely particular, growing up, and I had grown up in a family where there was always a bread, whether it was a roll or a piece of toast, there was always that option placed on the table. And so when I was starting to make dinners for my family, that was always that was just the expectation, and my son, we kind of, I place the meal on the table and we kind of say, I get to decide what, where, and when you're eating, and you decide how much, and we're not going to cross you, stay in your lane. And then I realized that he would only eat the bread, and he would sustain himself on only the bread. And so then I'm like, okay, well, the bread isn't bad, but we need to reframe how we're looking at our meals. And so then we just stopped putting bread out, and then slowly, after being exposed to so many broccolis, we had a piece of broccoli that was, consumed. And so, but it's a long process, and it's really hard, and it's really hard for parents. And you have parents that are, trying to make, ends meet. Fresh produce is really expensive. And so, learning some of the tricks, if you're like, okay, well, it's a good idea for me to have some of these here, canned vegetables are not bad. They're most of the time picked at Prime Fresh's frozen items. You can always get those at a lower cost, and so that you can manipulate some of those concepts and just being open to what's available to you, either financially or in your climate, in where you live, what your grocery store has at the moment, but.
I think one part of the problem that I have with the food pyramid are the pictures that they chose to put on it, because it seems like the pictures don't necessarily match the wording when you read it.
Yes.
People don't usually read the wording.
Yes.
So one of the big criticisms was that they kept kind of the same recommendation of saturated fat, so below 10%, but all of the pictures on the top of the big part of the pyramid are, for the most part, heavily saturated fat.
Fats. Yes.
And they make recommendations about produce, but they don't depict it.
Yes. And
I don't know how intentional that was, or if it was just an oversight. But I think that loses some of that nuance where it's, there are like plant sources of protein
yes.
that are also carbohydrates. So you can, if you're looking at increasing your protein intake and you don't, and meat is expensive, or you can't get quality, but you can get access to beans or beans and rice or frozen vegetables and different things like that. You can still get a lot of, there are incredibly healthy vegans out there
yes.
who get all of their protein from plant sources and things like...
And you can get all of your amino acids from plant sources. There is not an amino acid that you cannot get from a plant source. Do you have to be more intentional about making sure that your diet contains all of those important amino acids and proteins? Yes. Sometimes I don't necessarily discourage young people or teenagers to go vegetarian or vegan, but we talk about that. You do have to be intentional. You have to be knowledgeable about where your balance is coming from if you're not getting it from a more straightforward source. And I think that when you're looking or using a pictorial graph, the images that you use have to be on point. They have to be, because then it just becomes extremely misleading. You have some families with, concerns about literacy that are really truly just looking at the picture. And a lot of times the picture says 1,000 words. If the pictures aren't matching what you're trying to promote, then that becomes very difficult. Then you really truly have the fats as this evil, only 10%, and these are the bad things, right? And yes, we want to decrease our saturated fat, but fat in and of itself is actually a really incredible macronutrient that keeps kids fuller longer, and we have really incredible sources of fats that can really sustain kids, and plenty of avocados out there. And others that can give them that good nutrition. The nuts, nuts have a higher fat content. That doesn't mean that they're bad. They can be really good part of that day-to-day nutrition.
Yeah, but then it gets so polarizing too, because now you're going into a micronutrient that, depending on what generation you come from, because there's going to be a lot of parents out there who were raised in the 80s and 90s who are like, oh, fat's bad. You know what I mean? Like, I feel like we go through these waves of dietary dogma, and depending on what age you are at a certain time, you kind of cling to those things. And I see it in the different generations of my patients where, there are certain people, just demographic wise, who are going to have certain beliefs because that was the popular thing when they were younger.
Yes.
And I wonder with this trend now, because this is informing another generation. There's an impressionable generation who went through the flipping of the food pyramid. So I wonder what the long-term effects for that group are going to be, because they'll have kids at some point, or they are having kids. What, from a positive standpoint, what's the, if people decide to follow this more so than they've followed other guidelines, what positive things do you think could come of flipping the food pyramid?
My hope is that, and this may change, I think, one of the things that's difficult is that there are companies whose primary goal is profit that have a large say in how some of these things get promoted. But I think that at least right now, major concepts are that there is less processed food or category 4 food that is emphasized. And then as you're going up the ladder, that's potentially going towards that more processed or category 4 foods. When we're kind of talking like category of process, from slight processed versus like ultra processed, one common example is an unprocessed or category 1 food would be an apple. A category 2 somewhat processed would be applesauce. And then category 3 would be apple pie. It still has apples in it, but it has a lot of other things. And then category 5 or 4 would be like apple flavored candy, right? Or like gummy bears or, fruit snacks, right? Like you kind of further removed from the apple itself. And I think that at least for right now, when your focus is flipping the pyramid, is that you are hopefully causing people pause, and that the things that you're emphasizing are things that have the habit of being closer to the 1 to 2 category and further away from the 3 to 4.
Based on the pictures on there, that they are depicting things that are high in saturated fats.
Yes.
While at the same time verbally demonizing seed oils.
Yes.
Even so much that restaurants are now proclaiming to switch.
Yes.
So if this food pyramid works and it gets people to change and they're successful, it's very likely that we'll see an increased consumption
of
saturated fats.
Yes.
Which, Secretary Kennedy said he's ending the war on saturated fats. I think that was his phrase. It seems like, though, from my limited research, that there's a lot of evidence that suggests that increasing the consumption of saturated fats is related to heart disease.
Yes.
And decreasing saturated fats is heavily linked to decreasing your risk for heart disease. Yes. It's not a cause or effect relationship as far as I can tell, but there's an association.
Yes.
So if a bunch of parents now are making this shift early on and increasing, and we see over the next couple decades of these young kids' lives a drastic increase in saturated fats, where are you with the saturated fat? Because I would imagine if we had RFK Jr. here, he would say it's not going to have any effect.
Yes.
They're going to be plenty healthy. And I think there are a lot of people out there who make that argument. Apparently in their mind, there's some convincing research. Where are you on that? Do you think, like, if this shift happens and we drastically increase the consumption of saturated fats, what is that going to, like, what's your patient population going to look like in the future?
I do worry about that, because when you kind of demonize something and remove it and then try to replace it with something else, i.e. we've demonized saturated fats, now we're going to be like, yes, everything. When you go through there, historically, we have never had great outcomes. Yeah. We just haven't. And again, working on what that balance is. We're not saying no saturated fats, not ever, and looking at where that is, but also looking at our balance, understanding what those things do within our body. And one of the things that we do realize is that not always, but many times, saturated fats are found in higher quantities of very inflammatory, more processed foods. And so if you are looking at it, I think that increased saturated fat consumption is going to have an effect on cholesterol levels? Probably not, right? Because we know that that's not really what's driving fat in our blood. And that sugar and inflammatory foods are kind of what impact the fat and inflammation in our blood. But I do think that it's going to have an ill effect on the overall health. I worry about things like blood pressure or diabetes, other inflammatory conditions that I know that having high content of saturated fat has impact on. I don't know if that is that,
Yeah, because we can't know.
We can't.
It's one of those things that I feel like there's cause for concern just because heart disease is the number one issue that we have now. I think it's the number one killer of men and women, and it's largely preventable.
Yes.
And then I look at this shift, and I'm just like, well, okay, if you make a big change, you could fix a lot of things, but you could mess up a lot of things.
Yes.
So any change I don't think is good or bad. It just is, and then there's going to be effects.
Yes.
Positive or negative. So I wonder if this is if things go well in some categories, I wonder, to me, looking at it, it's like this is where it's, in my mind, where it's going to fail.
Yes.
You might see a lot of some things improve, but I just can't see, unless we're going to go down the route of all the research is flawed and bought for.
Yes.
You know what I mean? Like,
yes.
And that is...
And then we can't do anything. We're just a free-for-all.
That is a counter argument where people will say, and it's coming out a lot more, that, oh, there's just so much influence from big beef and all these other things, and it's like, okay, well, if we're gonna go that route and throw all the research out, like, I don't know, that's just,
then you're just left with nothing.
So we're just doing stuff then, and I don't know, we can't make informed decisions, so I don't know.
And I think and so that's why I'm always careful not to demonize any one particular food. When you talk about generational things, you have that whole, there's no more fat. All fat is bad, and everything is going to be fat free. We're going to have
margarine.
Right. Everything's moved towards this. And whether you believe that research is flawed or that there's bias in our research, which there's always bias in our research, and we try to kind of at least be aware and have that kind of at least be informed of that, maybe, so that we can kind of take what we're looking at with a broader view. We can look historically at what happens when we do that, right? We can say, okay, we may not know what will happen if we overemphasize saturated fat yet, right? We have some suspicion, right? But we don't know exactly. But we do know that when we removed fat and supplemented with sugar, that the health of our nation got significantly worse. And it's not that sugar is bad, right? But we shouldn't be replacing, right? We shouldn't be removing or demonizing one thing and then trying to up the ante on another. This is the healthy cookies are, my cookie is okay because it's gluten-free or it's sugar-free or it's still a cookie. It's still, looking at the quality of what's going in, not necessarily that there is one type of macronutrient that's bad, looking again for the balance.
But then, I mean, if let's say you have a group of people and you say, I'm just going to make fresh produce available to you year-round at either free or an incredibly reasonable price. We'll even deliver it to your house. There's a large part of the poor population that just won't eat it. They don't know how to cook it properly. They don't like the flavor. They've never been exposed to it. And unfortunately, now we have generations that haven't had home-cooked meals. It's been a lot of processed foods.
Yeah.
So we run into that thing that's going to complicate it anyway. People are going to look at even if they look at the pyramid and they're not confused, but they don't, like, what do they do?
Yes.
If I don't like these foods, I don't know how to prepare them, even if you were going to give them to them. And I think I remember talking to Denise Levenger, the hospital experimented with that with a food bank where they took out a lot of the processed foods and they put a lot of fresh produce in there, and it just went bad.
Yes.
People weren't, if you gave them the choice to select something, they were not selecting higher quality foods. And I can't think that that's due to the food pyramid being in a different orientation. Yeah. You know what I mean?
Yes.
Just turning this 180 degrees. I can't imagine people are going to walk into a grocery store now and be like, oh,
now I'm going to
I love carrots all of a sudden.
Yes.
This is a good choice for me. So part of me just thinks that it's just political noise and no one's going to change anyway.
Yeah.
But I hope that there could be some good that comes out of it. Maybe just with conversations, people saying, well, this is weird. And then they ask
And then
you about it.
Is it the question that then helps them bring it up to their doctor or their healthcare provider, that starts the conversation rolling.
Yeah.
And I think that has the possibility, and I really hope that spurs on change. But you're right, if we have generational poverty, or is this poverty of information, poverty of exposure to these, then it is going to be hard. You are building a palate for fresh fruits and vegetables. And so if we're starting to expose small children or infants, toddlers, to processed, highly palatable, highly addictive foods early on, then that sets the stage for their willingness to try these things their whole lives. And that's hard to do. Then you're really battling a lot of different things just because they've never had the opportunity to really cook or make or be exposed to how vegetables or fruits are grown, all of that. I mean, we're not living in the era of victory gardens anymore, where families are having their own gardens to kind of supplement or create the produce that they may or may not be able to afford in the grocery store.
Maybe that's the reasoning behind it. Maybe they're not playing checkers, they're playing chess. They're saying, let's just create chaos so people actually talk to their pediatricians.
I would hope so.
I'll give them the benefit of the doubt.
Yes.
But on this topic, GLP-1s for kids.
Yes.
Because GLP-1s are being demonized.
Yes.
And I had a student come up to me this week and needed to talk in private because the student was so self-conscious about being on the medication and didn't want anyone to know.
Yes.
And I'm agnostic. If it gets prescribed to you and you need it, then cool. It's like blood pressure medication. I don't care. So I don't have that stigma. And I was almost taken off guard about how guarded the student was about looking over the shoulder, not wanting anyone to hear the conversation, not wanting to be stigmatized. And I felt really bad for the student. And this is a college student, so probably late teens, early 20s, but we're seeing, I'm assuming that they're prescribing that medication younger and younger even than that. Do you think GLP-1s is there ever a case for when a young child, let's say I don't know, what's the youngest that you think that those medications would be valuable?
That really depends individually on each case. The complexity of obesity with diabetes, I think, is so difficult. When you're looking at the brain chemistry that is linked to how obesity occurs within families, generations, and individuals, whether there's life circumstances, medications, again, genetics, that can lead to obesity. I've heard it said that we live in an obesogenic society. So much of our society is based around an environment that promotes obesity. And maybe this is part of this idea of, well, let's flip everything around and change everything. What we're doing right now is leading to so much obesity. What if we do the exact opposite? But I think that there is a place for children to have access to medicines that can help with how their brains interact with sugars. And that's kind of the concept behind the GLP-1. And not only GLP-1s, but other medications that then turn down the volume on food noise and help them so that they are feeling full sooner, so that we can kind of decrease their total calorie intake. It's a hard thing for a child who has had a history of excess caloric intake that's more than what they can possibly expend in their play or lack thereof, and then to tell them that they're not hungry, and truly believe that they are, and I believe that their brains are giving them the hunger signal. So then how are you balancing that? And if you do balance that and be like, well, I'm not going to let this child eat in calorie excess, you actually release hormones from your gut and your brain that then increases that food noise. That ghrelin increases your hunger drive and increases your fat storage. So anything that we can do to help in those situations by either increasing fiber or increasing protein so that we can kind of decrease that food noise. But for some cases, there really is a case for these medications, whether they're appetite suppressants or used for diabetes, to help these individuals and families just have a leg up on a very difficult situation.
Yeah, I feel like if you can get it, it's hard because if you just decide, well, we're just going to let nature take its course and see what happens, which is one way to deal with it. The kid could have a growth spurt. They could change their diet. They could get into sports. They could get a complete shift because their hormones are going to shift as they change and grow. But what if that doesn't happen? Because it doesn't happen to a lot of people. Yeah. And now you rolled the dice. This person now is in their early 20s, and they've got over a decade of obesity, and it's not getting better.
Yes.
And so there's been damage that's been done cardiovascularly, probably that isn't going to be fixed. There's just so many things that we could have addressed. But then there's the other side of it where people are saying, well, everyone's just going to live on medication.
Yes, right. So, is fat the evil word, or weight, or what is our goal? What are we trying to achieve? And I think that that's important too, like especially when you're talking to children about weight and how we're looking at this and growth and different growth patterns. If you have two parents that are, 6 foot and, 200 pounds or plus, you're not going to be 5'4" and 110 pounds. Like this is genetically, that's not going to happen. So you have to look at where you're growing. What does that look like for your family? And certainly I'm not saying that everybody needs to be on a GLP-1 or everybody needs to fit into this very narrow BMI box, right? Like that should never be our goal. But we do have some families that truly, truly struggle, that you can see over time a growth pattern of obesity that is unlikely to resolve on its own. And we know that not only statistically, but you can see like some will go up on their growth chart and then they just shoot up as opposed to having any type of consistency of growth. That type of growth pattern or that type of obesity rarely, if ever, reverses. That type is not going to you're not going to just get taller. Sometimes you can have those little mini fluctuations. That's not what we're talking about when we're talking about medicating children for, or assisting with appetite suppression or anti-obesity medications. That's not the scenario. This isn't like vanity 5 pounds I want to fit into my prom dress. It's really, truly those kids that are staring at a barrel of a gun for really a lifelong difficulty with chronic illness that just takes life out of their life,
Well, I think so. There are a lot of people who are just like violently opposed to these, and a lot of them are in the alternative health space and the fitness space, and I think if I'm going to give you an extreme version of these conspiracy theories, it's you've got big food over here plotting to make money off of an unhealthy population, and then you've got insurance companies saying, yeah, we could kind of profit off this, and then you've got the medical industry being like, oh, well, pharmaceuticals, like we can make a drug for that. So you guys create the problem.
Yes.
We'll create the solution. And then we've got insurance companies. You're going to be the intermediary.
Yes.
So like it's like a money laundering scheme.
Yes.
And you as a physician, you're just like the drug dealer.
Yeah.
Essentially. You're like the lowest rung of like, you're the scummiest. Like,
yes.
But
totally.
that is the literally the type of terminology that gets used. I've heard, especially with pediatricians, people talking about pediatricians in my alternative health space, saying things like these pediatricians don't know what they're doing. They're part of the problem.
Yeah.
They're giving these drugs to kids, and I don't know. It makes me sad to think about it, and I'm sure there are people out there abusing it, but I feel like having had that experience recently with a student who was so concerned about talking about it that the student was literally looking over their shoulder to make sure no one was in earshot.
Shame and
it's like, well, what, who? And this student was also concerned about, we were in a gym environment, about people, judging what the person was doing. And I was like, look, 99% of the people in this gym are hoping you don't look at them.
Yes.
Even the fit athletes, they're some of the most insecure people you're ever going to meet. They don't want you judging them. They're not making eye contact because they don't care what you're doing.
Yeah.
And I was like, there's probably like 1% of the people in here who are jerks, and they are judging you. But they're going to judge you at the grocery store or in the parking lot or everywhere. They're around. Yeah. Like, this isn't a consolidation of mean people. It's pretty much this. It's probably actually, you're going to get less judgment in an environment like a gym or something like that, because it attracts a lot of self-conscious people who want to make changes.
Yeah.
They're a little bit more empathetic to what you're trying to do. But even with that, the student was having trouble admitting out loud that they were taking this medication that could be, and I didn't ask the student about their health background, but I wonder how many people are not going to have this conversation with someone like you because they're like, well, I'm not going to do that to my kids, or I'm not going to let my kid have this conversation, or we're not going to go that route. They're just closed off to the information because they automatically think that this is a shortcut and it's quitting and it's over medicalization and there's all these different things, and sometimes people won't even have those conversations, or they are ashamed, I guess, to have the conversation.
Well, and if that's the only thing you're doing, you're missing the point. Are there prescribers out there that are only just prescribing, that aren't having the sit-down conversation, that aren't trying to work through all the components to optimize health? Then yeah, that is irresponsible. There has to be so much more, because it's never really, or shouldn't be, a one and done or specific endpoint, and then once you're done with this, then you can just go back to eating whatever you want. But a stepping stool so that you can learn, especially for children, a stepping stool so that you can learn to better trust what your brain is telling you and be more successful in eating foods that kind of optimize your health. And I think that becomes easier with less food noise. And I don't know this yet because everything is still really new. And do we need more information? Do we need to know what long-term impact that we have by appetite suppression in children? Most definitely, we do, right? We should never stop research and never stop learning. But I think that for a child who's growing, to have an impact sooner on how their brain and gut pathway works, I think can have a bigger impact than doing this to an adult. If you can teach that and get that as they're growing, your goal isn't really, for most of the time, your goal isn't weight loss, but just slowing the accelerated weight gain while they're growing. Teach them those skills to listen to their brain, listen to their gut, making sure they're getting enough fluids, increasing fiber, working on protein, working on the quality foods, having all of that there where you're not battling all of that food noise for sugar, or, processed foods and the hunger. and you give them an even playing field to be more successful, that's really incredible. I also find, without being too judgmental, that the loudest people against this are people who have never struggled with that food noise and have never struggled with this. It's very easy to sit in judgment of someone who struggles if you've never gone through that, if you've never kind of really struggled, or if your family has never had the ups and downs of yo-yo dieting and weight gain and then weight loss and then weight gain again, and how much that impacts your feelings of success or self-worth, shame, embarrassment. Like, there's a lot that goes into that. And that complexity, you can't just ignore that and can't just say, okay, well, you're using this tool. I've never struggled with that, but I'm going to judge you for having that struggle and not just being able to do it because you falsely think that this is a willpower thing alone.
Yeah. I wonder too, so if we were going to do more research on it, I know with adults, they generally recommend most people stay on it for their whole life. But I wonder, that would be interesting if you took children and then you were able to reduce the food noise and then sustain that.
Yes.
The weight stabilized, pattern, like eating patterns changed. And then at some point, under the guidance of a physician, if you could wean, if that's a population that could potentially wean off of it, so early exposure could just be this thing to like basically like pick them up and put them on a different track in life and then take them off of it.
See if they would be more successful. We don't know yet.
Yeah,
but
that'd be interesting.
I do see that children would have just the nature of brain neuroplasticity and learning those. I suspect, I hypothesize that we would find that they would be more successful in a weaning process than an adult would.
That's interesting. Well, hopefully the pharmaceutical company doesn't hide all the research.
That's right.
I don't know.
Yeah.
I'm trying to be a conspiracy theorist now, but
I like it. We'll get you a tin hat.
Yeah.
Tinfoil hat.
Let's shift to vaccines.
Okay.
This is always a spicy topic.
It is.
And it's even spicier now because the last time we talked, we were thinking, I wonder what will happen if there's a new administration, because there was a lot of what ifs. Now we're well into it, and recently the CDC adjusted the federal guidelines for the vaccine schedule.
Yes. Can
you explain the changes?
So, yes, there's a few changes. The first change that came about with regards to the MMR and varicella, that are two. MMR is one, varicella, which is chickenpox, MMR, measles, mumps, rubella. Those are two live vaccines that are given at 1 and given at 4, typically. And that there is a combination vaccine that combines both of them together, since they're given at the same time. The idea being, if these are two vaccines that are given at the same time, they're both live, then we can combine it so it's one poke instead of two. And live vaccines are not better or worse. They're just live. It's what the body needs it to be to have an appropriate immune response to create immunity. So this combination vaccine was created to combine both of those two vaccines, the MMR and the varicella. And when they first did that, there was a slight increased risk of febrile seizure when given at 1. And not really so much at 1, but if you had someone who was slightly delayed, they were a little older than 1, that was a population that was having this slight increased risk of febrile seizures. And when we're talking about this, it's maybe just a few percentage points greater than febrile seizure risk at baseline. Plus, we're also creating an immune response, and one of the immune responses that your body can have to create antibodies and immunity against the viruses that we're trying to protect them is a fever, and if they're prone to febrile seizures, then this happens. So hopefully that's making sense. I know it's kind of a convoluted way to explain that, but
so it increases the risk of fever, but that's part of the process
of having
if
immunity.
You're prone
yes.
to seizures with fever, you would,
then that very well could happen. This risk was very small, but it is significant when you're looking at it. It was it was enough when we're doing the studies, not just say, okay, well, 3 people did it, but it was enough to have that, but still a very small number. Knowing this, most physicians, myself included, have never given the MMR varicella combined at a year because I don't want to deal with febrile seizures. I know the parents don't want to deal with febrile seizures, and they're one, and it's just easier to give them the 2 vaccines than have to worry about that. And as should be the case, a conversation that I have every single time I give vaccines at the 1-year mark is to say, okay, these are these 2 vaccines. Yes, there's a vaccine that's available that combines these. I am choosing not to give this to your child because I don't want this very low side effect to happen. Even though that risk is very low, I would rather just give the two vaccines, and the parents, agree, and we move on from there. I am not alone in that. I don't know if I'm alone or not in that conversation because I'm not in doctors' offices other than my own, but I know that I'm not alone in the pattern of not giving that vaccine as a combination vaccine. In fact, I want to say that when I was looking this up, like 95 to 98% of physicians do not give that combination at one. Okay, so we make a rule, or this rule that we're not going to do this, or that we're recommending that we don't give this vaccine at one, and very few doctors are actually doing that. Yeah. The good majority are not giving it because everybody is aware of that already. And so there's some thought process that for those families that don't have regular access to doctors, that have a very small window, or that have a lot of poke anxiety, that would be a good option. So I think that is why some of the different healthcare bodies were kind of pushing back on making this recommendation that not very many people are doing anyway. But that was that first big movement there was with that combination one. And then more recently with some of the other vaccines that were coming out with the hepatitis B and meningitis, there's other ones that then they removed from the standard schedule and kind of put it in place to say, this is no longer going to be part of the routine vaccine schedule on the CDC, but one that you need to talk to your doctor about specifically if this is something that makes sense for your population. Again, I think this is a conversation we should be having for the entirety of the whole vaccine schedule. These should always be conversations, not because the CDC says something or the American Academy of Pediatrics says something, but because you should always ask questions about what a doctor is doing or recommending for your child or for yourself for that matter. That should always be a conversation. And it also kind of, I think historically, I think a lot of medicine was based on, the CDC says or AAP says. And we have learned more now that there is a lot of politics that are involved in those. And so if for nothing else, we've learned to be cautious and question governing bodies, then I think that my hope is this moves us to a better state of health, right? To know that we should always question. But to create some that are arbitrarily ones that you have a conversation with your doctor versus others that are recommended doesn't make sense to me. I think they all should be. I think you should discuss all of them with your doctor, and I think that should be the case for everything. It's nice to have the schedule. The schedule is set up to maximize immunity during an infant's or a child's greatest risk of disease exposure. And so that's why it's created, and that's why the schedule is the way it is, but you should always ask questions.
So the AAP is not necessarily on board with the new recommendations. So you suspect it's more of just like political posturing, because most of physicians were already doing the new recommendations. So they're this body that's representing all of these pediatricians.
Yes.
And all the pediatricians are saying, well, we're already kind of doing that.
Yes.
And they're saying, well, we're still not going to change what we do. What's the holdout there?
I think the holdout there is my hope is that the holdout is that they realize that this is just something that should be happening already, that these conversations are something that are happening already. I think that they worry that pediatricians' jobs can be difficult. We're asked to put a lot of information and do a lot of things in a very small window of time. And so that if there is a body of evidence or information that we can give and supply, and a governing body that the public hopefully trusts, then we can make that one less thing to have to go into great detail, because then you can trust this group to kind of like help you through. Be like, hey, this is what my doctor is doing. They're following these recommendations. This is why. And we can move on from there. And I think that that's the effort, is to potentially help in that situation. But I think that there's been trust that has been eroded in both governing bodies, both the CDC and the AAP, that has made that sometimes a little more difficult. And I think it's going to take a long time to rebuild that. But I think that always should have been something that we've done smaller and in the doctor's office.
Makes it complicated, though, the fact that maybe a lot of people don't realize that that AAP doesn't recognize, they don't get along. Maybe that's news to people who are listening to this. But it's frustrating as a parent, because then you have to pick a side in a way.
Yeah. Yeah.
Where you feel like you have to pick a side, and then you have to sit, if you don't have a good relationship with your pediatrician.
Yep.
Well, whose side are they on? Are they on the right side?
Yep.
You know what I mean? It becomes really polarizing, instead of all of us saying, look, we have common ground. Yep. We don't 100% agree, but there are some benefits to this. You know, we were already doing this anyway. We just have to hammer out the fine points. But instead, it's like this posturing.
Yes. Yeah.
And so, you made a point earlier that a lot of people don't have routine access, so they may go to a clinic and see a different doctor every time. So there is no relationship.
Yeah.
And there's no conversation.
Yeah.
So then that's got to be a really tough situation.
And if you're doing that, you've never really seen a family before, you're trying to just give the routine vaccines, then it's hard to have those conversations. Yeah. I think for me, it changed how I do things. I realized that the questions that I was going to get were going to be more difficult. And so I needed to know the nuance of what was in the vaccines, why were in the vaccines, why was someone going to have trouble with or have legitimate concerns about aluminum in vaccines. Why are they going to have potentially not necessarily pushback, but valid questions about safety and efficacy? And so I guess for me, even though I was frustrated by some of this back and forth, and that we have two bodies that don't necessarily align in their recommendations or their global recommendations, it caused me to be more educated so that I could have more in-depth conversations. And I can say, okay, this is why the AAP is saying this. This is why the CDC is saying this. This is what our disease rates are in the state of Michigan. And this is why I have the recommendations for my office based on all of this information combined. So, but it is hard. It's, they say time is money. It takes more time to do it this way. And it costs more in healthcare to do this, but I do think that it's money well spent.
If these recommendations and these feuds ultimately end up in lower vaccination rates.
Oh, they most certainly will.
Obviously, you give vaccines, so it's safe to assume you see vaccines as largely safe and effective, with nuance depending on the individual patient, because I'm sure you have patients that for various reasons can't receive vaccines. I on the outside looking in, just from a public health perspective, I'm conflicted because I don't want to tell people what to do with their bodies or their kids' bodies. So it's hard for me to be hard for me to vote in a way where I feel like I would be creating laws or contributing to laws that are going to mandate that people do things with their children's health that they don't want to do.
Yes.
But at the same time, you don't want public health issues.
Yes.
And so I think when we watch these things on the internet or you see politicians, they've already made up their mind. It's black and white. It's one side's good, the other side's bad. But most of us sit in the middle and we can acknowledge, even if you're anti-vaccine, that public health, we're obviously in a better place for public health now because infectious disease is not as big of a problem as it was 100 years ago.
Yes.
But could it be? Yeah. Like, are we going back in that direction? That's why, I wondered. It's hard because, again, we're speculating on what's going to happen. But if this ends up resulting in exponentially lower rates of vaccines, do you suspect we're going to see some public health issues?
Oh, I know we will. Okay. Yeah. I mean, I just have the epidemiology background to know that we're losing our herd immunity. And it will happen. The diseases aren't gone. Measles is now back. We will have organic or from the United States measles, whereas for many years the only cases that we really had were coming in from outside. But we will. That we know that because other than smallpox, which was eradicated, we have no other disease process. We were close with polio, so close to eradicating polio, but we haven't. And we see those diseases rise. We had, again, polio is a great example. So close to eradicating polio, but we missed the small little window of opportunity because of a war that was happening abroad that could not get health officials in to get the polio vaccines there. And now our numbers are starting to creep up. Just that one miss, that one small window because of a war, and that we couldn't do that, and we see those numbers rising. We will watch as the herd immunity decreases, diseases rise. We have all the historical evidence that we need. Even if you're not necessarily, believing all of the big pharma information that's out there, historically we can see that when our immunity rates decrease, that our disease rates increase. And so that's what happens. I do believe and know that vaccines are some of the most important, not the most important, but some of the most important things that we can do to keep the public healthy. But I also know that forcing vaccines on a population does not get you there. And so my goal is to keep our community and children as healthy as possible, and to do that in the best way I can. And I know that strong arming people rarely works, especially with Americans, just because we're strong-willed and we've got opinions and we have disagreements. And I think that's part of what's great about that is being able to have those disagreements without necessarily, or at least up until recently, I felt like you could disagree and still be friendly. But yes, so if the end goal is, vaccinating and educating as many people as possible, historically strong arming people has not been successful. And so if success is your goal, then we have to come about it a different way. And you'll always have, I was not aware of the mother who was watching her sick child with measles and would still not get the vaccine. That is a little bit heartbreaking. I don't know that story. I hope it's not true, but you will always have those people that do that. I think sometimes not everyone that has questions about vaccines are anti-vaxxers, and I don't think that anti-vaxxers are bad parents. There are some people that are against vaccines, and it is a part of their like identity and almost their belief system. And those people are very hard to change. And no matter what you do, I don't know if their minds will be changed. It's so ingrained in that self-identification.
It's hard too, because I feel like now we get so much information from social media,
Yeah.
and the algorithms are just so, like that story that I told you before we started recording. I don't know if that's true either. It came off a social media algorithm.
Yeah.
And a reporter who I think to be credible was talking about it on social media, but there was just a caption, and apparently the kids in the hospital for measles and not doing well, and the mother had stated that she would rather that than the complications or the injecting something into her child. So that could be completely false.
Yeah.
It could be 100% made up by a bot.
Yeah.
So I don't even know, and that's another hard thing is I think so many people make decisions with very little information, but the popular media and social media, they're so good at like getting your attention and then finding that nerve and then radicalizing and mobilizing people to go repeat things.
And then filling your feed with more that supports that.
Yeah. And so people are just, well, I've been doing my research, and it's like, oh my gosh, well, what does that even mean? You know, because it's hard, even if people did the research and they read papers, there's so much nuance to reading a peer-reviewed paper, especially something big like a meta-analysis.
Yeah.
And so
even if it, was it a randomized controlled study, you should really talk to someone about statins, because that's another hot button one. And it's incredible. And you look at some of the studies that people will reference, either with vaccines or with statins, with any of that. And it's taking some of their findings and making leaps that you can't necessarily conclude, like associations versus causations. Like just because something was associated didn't mean that thing caused it, right? And learning that nuance, or learning the quality of the study, and whether the study was designed to give us a specific answer, or whether the study was made or resulted in something that had us ask more questions. Did it have us ask more questions to be like, hey, we need to look into this? What was that? That one of the things that they talk about is statins causing weight gain, right? So that's not what that study back in 10 years ago found, right? They found different eating patterns in completely two different subject groups. And so you have to look at the basis behind what that behavior was, and not that medicine caused that, but that maybe that because you were on a medicine that you felt like you could eat more, or that it negated what you were doing, or maybe it was a different population, and because they were so separate, like you couldn't make that, but it was enough for us to say, hey, let's look into this more, let's do more to find out more information. And I think some people take those preliminary studies and then they become fact, and you just can't do that.
Well, also, you could take something from a study and you could say, like, this is probable. And then you sensationalize it, and people go, okay, well, I am either going to make that decision or not make that decision. And it's like, okay, well, now there's a void, because what are you going to do?
Yeah.
Well, who fills that void?
Yeah.
So a good example is the Broken Science Initiative. It's Greg Glassman's project.
Okay.
And he gave a talk on Hillsdale College's campus a couple years ago about it. It's nothing, like, it's funny because it's nothing new from him. It's talking about all the stuff he talked about when he founded CrossFit. And I've even heard him on podcasts talk about how bored he is with talking about the same stuff. Yeah. It's like, my recommendations have not changed.
Yes.
It's just called something different now. But they're basically going through research and showing here's the flaws and different things. And I think one of their targets is statins, and like they have some problems with statin research. But it's interesting because I heard a podcast interview with him where someone asked him, what are the next steps? And he said, I don't know.
That's right.
He used the analogy of the emperor has new clothes, or the emperor's new clothes. He was like, that at the end of that, there's a young boy who walks out and goes, hey, the emperor's naked.
Yeah.
Well, that kid did not think about the repercussions of those actions.
Yes.
He didn't think about, am I going to be like, what's going to happen after?
Yes.
He was just pointing out something that he thought to be obvious. And Glassman said something to that effect. I am just pointing out what I think is obvious.
Yes.
I have no idea on the back end
what to
do about it. That's not I'm not a doctor. I'm not a researcher. I'm just looking at things. So I think it's great that we have people out there who are contrarian, who are looking at these things critically, but people will make decisions based off of that. And he himself is saying, well, I'm not giving you health advice beyond this. I'm just telling you that there's flawed research, that the science, that's why he calls it the broken science initiative. But I'll see people who will look at things like that, and they'll hear things like that, not just from the broken science initiative, but any influencer on Instagram will be like, oh, you shouldn't do this.
Yes.
And it's like, okay, you're not going to take statins anymore. Great. You still were put on them for a reason. So how are we going to correct that? Are you making major lifestyle changes? Are you making major dietary changes? Like, what are you doing? And a lot of times they're like, oh, I'm taking this rare supplement from the remote corner of Africa that is this a secret whatever mixed with Himalayan sea salt.
About.
Yeah. And it's like, and the commercial, if you look at it on the TV, it'll be like, this is what Big Pharma doesn't want you to know.
Yes.
Or what your doctor, what your pediatrician is not telling you. But that's literally what they fill the void with. So it's like, okay, the research, like let's say the research is flawed with some of these medications or some of these vaccines. Great. That's good to know. We need to investigate that. But also in the meantime, as the end user, you still have to make a choice. Either you're just going to do nothing, but there are going to be pros and cons to that, or you're going to look at an alternative.
Yes.
The sad thing is that the alternative to a lot of these things are just like, there's not only no evidence to support them, there's evidence to show that it could be harmful. So like, I'm not going to vaccinate my kids, but I'm going to give them raw milk.
Yes.
Well, okay, that's an interesting alternative, because if you don't think vaccine research is good, how do you feel about the research on raw milk? Because it seems like pasteurization saved a bunch of lives. So, and I'm not just picking on the raw milk people, because it's with supplements too. It's like, well, I'm not going to take statins.
Yes.
I'm going to take these 7 supplements.
Yes.
And it's like, oh, did the person who told you not to take statins, did they sell you the supplements?
Yes.
Because there's and that is a problem with...
You'll have families that are taking 8, 10, 12 pills a day, but it's not actual medicine. It's supplements. They're natural.
Yeah.
And you're like, or that they could be having an effect from all of these supplements, and you have very little idea of what's actually in them, and they're having side effects. And I'm like, if I had given you one pill that caused those side effects, you'd be so upset with me, and yet you're just, carte blanche, just taking all of these. Like, it doesn't seem right to me. Yes.
Well, that's a huge problem too, is we don't, the supplement industry is, I don't want to say it's unregulated, but it's poorly regulated. So it's regulated on the back end if something bad happens for the most part. Unless you're going to introduce something new to the market, we could just put anything out there. We could have a proprietary blend, good marketing. It doesn't, we could say I could get anyone to third party test it. No one's going to know. Put the right colors and images on, boom, we make a bunch of money. But I could sell that as an alternative to vaccines. Even if I'm being honest about the ingredients, the dose makes the poison or the medicine. So even, I think on a lot of supplements, there's not a therapeutic dose of whatever the key component is, or it might not even exist in there. So you would have no way of knowing, because there's no process to get it to market where you have to validate the effect, if it's safe and effective. So a lot of supplements, I don't see them as harmful. I just see them as, like, if there's no side effects, there's probably no positive effects. And I hate to think about it that way, but like, we think of like, oh, a medication has side effects. It has effects. It does stuff.
Yes.
The body just like people react to it different. We're hoping statistically that you're going to get the effects that you want, but you might not. But if someone's selling a supplement and it has no possible side effects, it's probably not going to have a therapeutic effect. Like I would find that very rare. I mean, there are some instances, I think, like maybe whey protein. Like, I don't know if there's any negative side effects to that, and there's some positives. So I don't want to speak in just say that like blanket statement, but it's like, it makes me think of the National Lampoon's Vegas Vacation.
Which one is that? Okay.
So with Chevy Chase,
yes,
he goes to Vegas.
Yes.
He gambles and loses a ton of money.
Oh, okay.
And the blackjack dealer that he goes to is the actor from Princess Bride, who's like inconceivable.
Oh, yes, yes.
So Clark Griswold's been losing a ton of money, and he walks up, he gets more money, he comes up with chips, and the dealer just goes, "Look, why don't we just save ourselves some time? You give me half of your money.
Yes.
We'll go out back. I'll kick you in the nuts, and we'll just call it a day." You know? And I feel like when people are going out and they're like, "Well, I'm not going to do all of that stuff, but I'm going to take a bunch of supplements." I just like, give me half the money you spent on it, and we'll just
call it a day.
You'll save money, and you'll get the same effects. And I think that it's a sad thing because people are led to believe that things will be beneficial for them. And it's just weird because it's like, let's take a medication that took X number of years to get to market.
Yeah.
And it's been on the market for X number of years and has known benefits. I could look at that and I could pinpoint the side effects and demonize it, and I can freak someone out, and I can turn them away from it.
Yeah.
And then so we've got this thing over here that maybe credibility wise is up here.
Yeah.
And then I can sell them something that has credibility wise is really down here, but the way I present it, I invert that, and that's marketing.
Yeah.
And I just don't think that a lot of people realize that that this happens to them all the time, and that there is actually an incentive. And the sad thing is that I think it seems like a lot of the people involved in HHS now are tied to those organizations. You know, we'll sit here and demonize big pharma and people taking money from them, and it's all bad and it's all happens. But the supplement company is like a multi-billion-dollar industry, and there are some people who are in some high positions in the federal government now who own supplement companies, and now you're able to use HSAs to spend money on their products that don't do anything. Yeah. Which is great that we are gaining more access, but you're gaining more access to magic beans.
We need a little bit more transparency.
Yeah, so it's like, this is evil. Don't do this. Come over here. I have the alternative. It's worthless, but it's not evil. Yeah. I don't know. Now I start to sound like a conspiracy theorist, but it's when I hear people are like, well, I'm not going to take medications. I'm not going to use vaccines. I'm not going to do all this stuff. And then I ask about the conversations they have, and a lot of people haven't had those conversations, or they have one opinion. Yeah. And not every physician's going to agree. And I always think that that's sad. But obviously, you're going to make an appointment to go talk to another doctor. That's a hard thing to do. So it's like, how is someone going to get that reasonably if I'm like, well, you should get a second opinion, and they're like, I got 8 kids, I'm not going to, what am I going to do? Yeah. And this is what my insurance pays for. I go here, this is my spot. So that's why I think it's nice from a podcast standpoint to at least offer a long form discussion so that people can get some nuance to some of these discussions, because there might be some anti-vaxxers listening to this who are like, oh, maybe I should ask more questions. That would be my only hope. Not that they start taking vaccines or that people go flush all their supplements down the toilet or anything like that, but that you just realize that the opinions that you're getting are probably biased. Yes. And it's not because the person's evil or bad. It's a person, and you just but just because someone told you one thing one time, or you heard it on Instagram, does not make it true.
Well, if you look at it and you look at the trajectory of medications or the trajectory of vaccinations, you can realize that the vaccines that we're giving now are less than, or the immune material is less than what we were giving 30 or 40 years ago. we're protecting against more diseases but less immune material. You can look at, and hopefully, my hope is that in 20 to 40 years, our vaccines are safer yet still, right? We should never be done with medicine. We should never be done with vaccines. We should never be like, okay, we got it. We're all done, unless we've eradicated a disease. But that you have that. And just because it's not as safe as it's going to be in 50 years doesn't mean that it doesn't have value now. We look at antihistamines. Benadryl is an antihistamine, and it helps if you're having an allergic reaction, seasonal allergies, bigger reactions, maybe not anaphylaxis, but it causes a lot of fatigue, and it has a very short half-life. We now have second generation antihistamines. So that's your Allegra, your Claritin, your Zyrtec, and all of which now are over the counter. They used to be, you got to get a prescription. Now they're over the counter. Now they all have generics. So I'm using their name brands, but they all have generics. Mm-hmm. And now a big shift is like, okay, now that we have these second generation antihistamines, we really should kind of push Benadryl aside, because we just have, they're longer acting, they last longer, their onset is a little faster, and they're just better with less side effects, right? Does that mean that if you needed Benadryl, 20 years ago, that you shouldn't have taken Benadryl 20 years ago? No, that was the best that we had, and it was important, and Benadryl probably saved quite a bit of lives from really severe reactions before they could get epinephrine or get into the hospital. So it had a really great benefit, but we just have something newer now that probably should take at least 95% of the market away from something like that Benadryl. Vaccines are the same way. I think it's great to point out flaws, and I think it's great to have the little boy that tells the emperor that he's naked. But to also realize that while there may be a flaw, that doesn't mean its reverse is true, and that there's only that, right? Like, yes, there may be flaws, and yes, we may need to have more medication, or we might have to have better cholesterol management, or we just need to be better about eating foods that help reduce our cholesterol, right? Yeah. But it doesn't necessarily mean, and I'm not a cardiologist, I know very little about statins, that it's bad in and of itself, or that it's an all or nothing thing.
Well, statins are an interesting one. I'm not a cardiologist either, but I take statins. Mm-hmm. My dad had heart disease. He had multiple heart attacks and open heart surgery. Mm-hmm. His dad had a heart attack. So there's safe to say there's some type of family history. Mm-hmm. When I was processing out of the Marine Corps, I was checking into a VA hospital for the first time. And I had a printed out medical record like this big. And this PA comes in, mm-hmm. and she looks at me, and she takes my blood pressure, or they take my blood pressure, and she was like, "Are you open to conversation about medication?"
Yeah.
And at the time, I was like, you know what I mean? I was mm-hmm. in my mid-30s. I was like, whatever. And she was like, okay, well, I'm looking at a family history,
yeah, and
a lot of high blood pressure in this medical record.
Yeah.
And she was like, you can either do something about it or you can die young. I think those are your two choices.
Wow.
And she was like, you don't have to take medication, but you better seriously experiment with some lifestyle changes. Mm-hmm. She's like, your cholesterol numbers suck and your blood pressure is chronically poor. Unless you just have white, like lab coat syndrome, white coat mm-hmm. syndrome, like there's a problem here.
Yeah.
So she was like, I highly recommend, if you're not going to talk to me about meds, that you go out right now to CVS and buy a blood pressure cuff, and you start monitoring your resting blood pressure and charting that and figuring this thing out.
Yeah.
And that led me on a path, because I was over 10 years ago, and it was like, I wish someone had that said that to me when I was like 20.
Yeah.
But no one ever just sat down point blank and was just kind of harsh with me about it. But like, mm-hmm. here's the facts, the way I see it.
Yeah.
And so I remember then me eventually going on statins. It was actually, I have my family, my provider here, Carl Wolf, is a PA over in mm-hmm. Jonesville. And we had the same conversation,
Yeah.
and he was much more compassionate about it, but it much for the same thing. And
Yeah.
I have a good relationship with Carl, and he was like, you got to make a change. And he's like, it seems to me that you're pretty fit,
Yeah.
and that you're doing all the lifestyle stuff,
Yes.
and it's not working.
Yeah.
Not the way we want. So he was like, would you be open to
Yeah.
trying it?
Yeah.
Try it for a year, the lowest dose we can. Let's see if it has any effect.
Yeah.
So I went on a statin and something for blood pressure, and it had a huge effect.
Yeah.
And I haven't had any side effects. So it's like, for me, it was like, well, okay, well,
Yeah.
my ignorance and my stubbornness and my beliefs based on things that I've been told
Yeah.
and that I didn't research or I thought I researched, they're incorrect. Now,
Yeah.
the interesting thing is that my dad had stumbled on red yeast rice before he died. And so he was taking it. So I was taking it. And red yeast rice is what they used to make statins. Like, apparently it's like monocolin K. There's the active component in red yeast rice. They noticed that people who were eating a lot of this in whatever Asian country had almost no heart. So like they synthesized it, and then, as Big Pharma does, if you get red yeast rice in the United States, it has to have the active ingredient removed because it's a medication now.
Yes.
So if you just go buy red yeast rice,
Yeah.
you're not getting the active component.
Yes.
And so I was like, well, who knows that?
And nobody.
Because I felt like I did my research
Yes.
to see like, oh, I'm going to take this alternative to the
Yeah.
medication because
Yeah.
this is the natural version of it.
That's incredible.
And Big Pharma was one step ahead and was like, well, no, technically that's a medicine now. And we're not just going to, like, it needs to be prescribed.
Wow.
Which I don't agree with. I wish they hadn't done that. And I'm not supporting that, but it just is to my knowledge, it's a fact.
Yeah.
So it's a frustrating thing when you don't go out and you don't have the opportunity or the courage or to have those conversations, or you don't have a provider who's going to spend the time with you because they're slammed and not because they don't care about you. And then you feel like you do your research, get on the internet, you use Google, and you find some stuff, and you get like 99% there, but that 1% you're missing is where the nuance is that you're not getting the active ingredient. So I was just like basically peeing out money.
Yes. Can you imagine
to not affect my heart?
how I feel as a pediatrician when I realize that so much of what I do has not only an impact on their health at that very moment, but for their whole lives. And when do you start that? When do you start? We have those conversations about the good foundations of health and trying to like empower families to do that and to make those big changes early. But when do you start having that conversation at 20, at 15, like, hey, your family history is going to set you up. You are going to have to work so much harder than the average person to keep your cholesterol down or to keep your blood pressure down. Like, you don't have the genetic luxury of being overweight because this is what you're looking at. This is the path or the track you're on. How do you take those children and young adults and like sort of plant them to a different track? It's hard.
Yeah.
It's a huge responsibility.
Because now in my 40s, they're talking about my 10-year risk. But
Yeah.
20 years ago,
Yeah.
it was a 30-year risk that I could have mitigated. And I don't blame any of my healthcare providers. I think it was a missed opportunity.
Yeah.
And things change. And maybe that PA was just having a bad day.
Yeah.
And she just felt like unloading on somebody. But I was just sitting there like, okay, well, I should do something. I
Yes.
literally went to the drugstore and bought a
The
blood
blood
pressure
pressure,
monitor
yeah.
that had an app associated with it so I could track it on my phone.
Yeah.
And I tracked my blood.
Yeah.
It started me on a path that may have extended my life decades, just because some PA was feeling sassy and she decided to just tell it to me straight.
That's right.
But and I'm thankful that happened in my 30s and not later. But then you have an interesting opportunity because you might tell it to people straight, and 1 out of 100 makes a change. But for that one who listens, or that family, it's like, okay, yeah, we should really take this seriously. It could mean everything. It's just, it's the difference. It puts you on a different trajectory. And I think that's a nice segue into my last question for you, is that I want to know if I got appointed by President Trump and he gave me the power, and I said, okay, Nikki, you are in charge of MAHA.
Ugh.
Yeah. And this is what we could do.
Yeah.
You can make as many changes as you want, but I can only guarantee that one change will last. And that change, I can 100% guarantee that no president for the next 100 years is going to be able to change this.
Yeah.
I can also guarantee, because I have a magic wand, that people will actually listen to it.
Okay.
Like, this is something that will actually be implemented throughout society, but you can only do one thing. We're going to put your name on it. So if it fails, it's on you.
It's on me.
What would be one thing that you think that would take us and put us on a different track?
I want to change schools. I want to change, and this is kind of two things, but I'm going to say schools so that I can get away with doing two things instead of just one.
Okay.
I want more recess, and I want to change school lunch and school meals. I think teaching children how to either make food or giving them good, nutritious food on a regular basis, starting at a young age, helps develop those eating patterns. And these are pretty small. So when you talk about studies and the quality of the studies, these are very small, anecdotal, and sometimes very small N group, N being how many study participants you have. But they have these small little pockets of schools that have gone to making the lunches on site, and using local, you're kind of like bougie farm to table kind of stuff. But doing that on site, and after enough exposures and giving them that opportunity to have real food, they develop that taste for it. And then I think that we could really make a big difference in adult nutrition by teaching kids how to do it. Home ec, like, where did home ec go? We have people who don't know how to make their own food. Let's go back. Let's teach them. Teach them when they're little, knife skills, cooking skills when they're in middle school, bring back home ec, make food in the schools, and more recess.
That's fascinating, because if you look at children who are obese, you could blame the parents, but the parents may have just been obese children at this, you know what I mean?
Yes.
How do you break that cycle? That could be a way
to do that.
For kids to be able to have the knowledge and make the decisions. That's interesting.
Yeah. Baked Alaska for everybody. Did you take home ec?
I don't think that we had it in my
I did.
high school.
That's the only thing I remember.
We still had
Baked Alaska.
We still had a shop class.
Oh, yep. I had that too.
So we had old school PE, and with the football coaches with the short polyester shorts, who just made us run laps and do push-ups.
Mine had two little dogs, Boston Terriers that would follow him around. I'm like, how is that even allowed at a school? Yeah. But he did.
Yeah. And then you had shop class. Yep. And I remember when I was in high school, they introduced a computer class that you had to take to graduate.
Oh, yeah.
So you had to know how to log on to the internet, apparently.
Yeah.
But I don't think we had a home ec.
Yeah.
But that would be cool, though.
Yeah.
That would be an interesting thing if it was a long term, middle school through high school. So you get 8 years.
8 years of learning how to prepare food and cook. Yeah. I think that's so important. You can't necessarily just assume that families are getting this at home. They don't have a frame of reference. And you could change it based on where they are in their fine motor skills and their development, and kind of teach them slowly how to do those.
Yeah.
Mm-hmm. I also think you have more specials is what my kids call it, the non-math, I think that the more that you have to break that up, the more that you can utilize what they're learning in home ec to help support what they're learning in the classroom, whether it be science or physics or mathematics and fractions and all of that. And you can use that in food and how food is made to help support that. I think that, I don't know, my hope is that we'd have improvement in scores too. Improvement in our STEM, because they're learning how to make their own bread, or learning in science class about yeast and then making their own sourdough starter. I'm a little crunchy that way.
Yeah. Well, no one's ever asked me to do differential equations.
No.
in life.
Yeah.
And no one's ever asked me to recite Shakespeare at a job interview.
Yeah.
And so I feel like we spend a lot of time with kids, and all these things are important because you're shaping the way the brain works and everything like that. But they do have to put food in their mouth every day for their whole life.
Yes.
So it is an interesting thing where we put the emphasis, you know, we got kids who are dying young, but they're good at fractions.
Yes.
But then if you look at the health or our education system, they're not even that good at fractions.
Yeah.
So it's like, if it's like, maybe you get to pick.
Yeah.
You know,
or just more real life application for the things that they're learning.
Yeah. If you're not going to be good at math, you better be able to run a mile and bake a cake.
That's right. That's right. Yeah.
Well, I think that's a good place to end it.
Thank you.
I appreciate you coming on again.
No problem. I'm happy to.